Hi, good afternoon, and welcome to my Institutional Review Board presentation for APN 615 Nutrition and Metabolism. My name is Lauren Sullivan, and I'm a registered dietitian. My presentation today discusses the effects of 3 different doses of vitamin D after gastric bypass surgery. Vitamin D is a topic of interest for me both personally and professionally. As you can see, I've been blessed with extremely fair skin. I also live in the United States in the Northern Hemisphere. I work full-time, I attend school, so I'm rarely exposed to sunlight, and I'm frequently in need of vitamin D supplementation myself. Professionally, I work with bariatric surgery patients on a daily basis, and I see the epidemic of hypovitaminosis D that is frequently described in the literature. The title of this IRB proposal is the effect of 3 different doses of vitamin D on 25 serum hydroxy levels for 24 months following Roux-en-Y gastric bypass in women ages 20 to 40 years. The main purpose of vitamin D in the body is maintenance of normal serum calcium and phosphorus levels needed for strong, healthy bones. It includes normal bone growth, bone mineralization, and it also reduces inflammation and functions in immune response. Obesity is a risk factor for hypovitaminosis D, and bariatric surgery is a frequently selected option for this. Studies have shown that up to 76 to 90% of patients coming in to have bariatric surgery have hypovitaminosis D. One common bariatric surgery, the Roux-en-Y gastric bypass, alters the anatomy by bypassing the entire duodenum, the upper part of the small intestine. This creates a permanent change in the absorption that occurs for calcium and phosphorus and vitamin D. This leads to osteomalacia and bone demineralizations. High-quality studies are needed to determine the efficacy of multiple vitamin D regimens following bypass surgery. Therefore, the proposed research question addresses this gap in the literature. The research question, do 3 different doses of vitamin D3 supplemented in women after Roux-en-Y gastric bypass surgery provide vitamin D status at 6, 12, and 24 months following bariatric surgery? The null hypothesis states that there's no difference between these groups, that the women in the ages of 20 to 40 years receiving either 3,000 or 5,000 or 6,000 international units of D supplementation per day at each of the intervals 6, 12, and 24 months post-surgery for Roux-en-Y gastric bypass. The alternative hypothesis states that there is a difference in the D25 hydroxy levels in females ages 20 to 40 years, receiving 3,000 international units versus 5,000 international units versus 6,000 international units per day of vitamin D3 supplementation at 6, 12, and 24 months post Roux-en-Y gastric bypass surgery. It's important to have a comprehensive understanding of this nutrient. Vitamin D is obtained from fish, from liver, from fatty fish, butter, fortified foods, liver, eggs, dairy products, dairy alternatives, margarines, and cereals. Vitamin D may also come from supplements. People consume them through supplement use. But mostly vitamin D is obtained through cutaneous synthesis from ultraviolet B radiation exposure. I have to say I'm a little jealous at the moment. 2 of my daughters are exposing themselves to UVB rays in Myrtle Beach as we speak. Thanks to my daughter Julia for this photo credit. Vitamin D presents itself inactively until a hydroxylation reaction occurs and it converts it to active vitamin D. This occurs in 2 places, the liver and the kidneys. The liver forms calcidiol, ergocalciferol vitamin D2, and 25-hydroxy vitamin D, all the same, different names for the same thing. In the kidneys will have a reaction that forms calcitriol, otherwise known as cholecalciferol vitamin D3, and 1,25-dihydroxy vitamin D. In summary, there are several factors causing low vitamin D levels in persons with obesity, including its storage in fat cells, the adipose tissue, lack of exposure to ultraviolet radiation, and poor diet. When a person selects gastric bypass as an option for the treatment of obesity, changes in the anatomy will cause altered absorption for life. The literature review shows studies have determined that safe and effective dosages haven't been yet identified. And so Moore in 2014 and Goldner in 2009 led prospective studies that respectively determined that 2,000 international units per day is insufficient and that 5,000 international units per day is effective in preventing deficiencies, but it did not meet the needs for all patients. Hollick in 2011 and Mechanic in 2013 led meta-analysis reviews to help establish practice guidelines for the Endocrine Society and for the American Society for Bariatric and Metabolic Surgery. Hollick determined that 6,000 to 10,000 international units per day were enough for patients who were getting malabsorptive diagnoses, including surgeries that cause malabsorption. The ASMBS was much less aggressive and deemed a dose of at least 3,000 international units per day as recommended for bariatric surgery patients. Lazzarini essentially dosed 1,500 to 1,600 units per day and determined that level was insufficient. Vicks and colleagues in 2014 strongly recommended aggressive pre-surgery treatment and suggested future studies to evaluate the difference in vitamin D regimens postoperatively. Other studies have been unable to determine the optimal dosage, but it has been clear that levels below 2,000 international units a day are not enough to sustain 25 hydroxyvitamin D levels of at least 30 nanograms per milliliter. The study is randomized and it's prospective, and the 3 doses of vitamin D are 3,000 international units per day, 5,000 international units per day, and 6,000 international units per day. Subject recruitment will include female patients ages 20 to 40 years that have completed a pre-surgery interdisciplinary clearance, and they are scheduled for Roux-en-Y gastric bypass. Subjects not meeting the age and gender recruitment goal will be excluded. Other exclusions will include women already in menopause, those having previous bariatric surgical history and medical diagnosis, conditions or medications that alter bone metabolism. Provisions to protect the personal health information have been made. The study will be taking place at a facility that follows the Health Insurance Portability and Accountability Act, otherwise known as HIPAA. The electronic medical record will be used to consent the parties, so there's no paper trail. The facility is also awarded the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, otherwise known as MBS EQUIP, and it designates that a program has a proven record of favorable outcomes for weight loss surgery. The consent process will take place in person 1 to 2 weeks prior to surgery. HIPAA will be reviewed. The subject will be provided with a written copy of how the data will be collected and used and receive the researcher contact information. Subjects may withdraw at any time. The research will be conducted at a large MBSA EQUIP academic medical center. 150 subjects will be consecutively enrolled in the program beginning in January of 2020. The methods include baseline labs, collecting data on anthropometrics and demographics of all patients coming into the bariatric program, not just those in the study. At 2 weeks prior to surgery, the patient will be consented if they're interested in participating in the study, and the same labs and body composition will be assessed 2 weeks prior to surgery, again at 6, 12, and 24 months post-operatively. All patients entering our program will receive vitamin D therapy if they have a deficiency prior to surgery. If the levels are between 25 and 30 nanograms per milliliters, they'll receive vitamin D3, 2,000 international units per day. If it's between 20 and 25, they'll get 50,000 of D2 a week for 8 weeks. And if their number is extremely deficient, less than 20 nanograms per milliliter, vitamin D2 will be provided for 12 weeks at 50,000 international units per week, and all patients will receive 1,200 milligrams of calcium carbonate per day till surgery. The subjects will be randomized into 3 groups, and vitamin D treatment will start 1 week post-surgery. Each group will have 50 subjects, the N50, and they will be randomized to either 3,000, 5,000, or 6,000 international units per day, all patients receiving 1,500 milligrams of calcium citrate following surgery. Post-surgery, all the vitamins and minerals will be provided based off of the ASMBS guidelines recommendations. There are risks associated with the study, but they are minimal to the patient. These include potential for hematoma or infection during the lab analysis, injury maybe while the bioimpedance analysis is occurring or while driving to and from the medical center. Adverse reactions may occur for the supplements, and there is always potential for confidentiality breaches in spite of our attempts to not have that happen. Also, patients might have issues with insufficient supplementation. There are benefits that are monetary. Parking vouchers will be provided to our patients and the subjects of this study, and they will also get free minerals for the duration of the 24-month study. Close monitoring of health status and lab values will occur as well. In the data analysis, a G-Power analysis was done showing a minimum sample size of 47. It was increased to 150 based off of the strength of the study. A 95% confidence interval was used with a medium effect size, the p-value of 0.05, and the a priori analysis critical value came in at 1.680374. A Wilcoxon signed rank test was selected for analysis of matched pairs and a t-test. The Institute statistician will be employed to expertly analyze the program and using quantitative descriptive statistics. An evaluation will include the percentage of weight loss, change in BMI, change in lean body mass, changes in lab values, including the 25 hydroxyvitamin D levels, calcium, alkaline phosphatase, albumin, intact parathyroid hormone, a number of things. The aggregate mean, median, and mode will be used to summarize each of these variables. An independent sample t-test, means standard deviations, will be used to report the changes in the 25 hydroxyvitamin D levels, the percent lean mass, and all of these things between the data points in relation to the preoperative vitamin D levels. One way ANOVA variances are going to be used for comparing several means, such as statistically significant differences between the means of the three groups and at the follow-up intervals, 24 months, 6 months, 12 months. There are greater than 2 population groups, so the t-test in this instance is not warranted. ANOVA may be used to compare the means of any lab data, weight, body fat percentage, or BMI between the study arms. The Kruskal-Wallis test will compare lab values between the three groups. The Fisher's exact test will also be used to look at the vitamin D level changes. A Pearson's correlation test will examine the relationship between the vitamin D concentrations in BMI, percent body fat, percent lean mass. Simple regression analysis may evaluate the vitamin D and the IPTH levels. The pairs comparison Wilcoxon rank sum test will compare vitamin D supplementation of those in all the groups with and without deficiencies. And the Spearman's correlation coefficients will show the association in the change in lab markers like calcium and IPTH and the change in 25-OHD since the baseline. I want to thank you and thank you for listening. Thank you for your input. I look forward to your comments. My references are attached, and have a great day today.